We are back. Journey to 600. Today we're going to talk about heart failure. So our agenda for today, we're going to talk about systolic dysfunction versus diastolic dysfunction. Then break it down by right heart failure versus left heart failure. What would a medical diagnosis look like? Then what are the classifications of heart failure? What is the medical management of heart failure? What can we do as PTs when exercising with heart failure? And then, of course, practice questions. So systolic versus diastolic dysfunction. So systolic, is that contraction of the heart. So it is an emptying dysfunction. So when it contracts, it cannot empty all the way. You will have dilated ventricles, a compromised contraction forces of the ventricles. So basically it's ineffective at pushing out blood, therefore emptying dysfunction. And when it cannot push out that blood, you're going to have a decreased stroke volume, therefore decreased cardiac output and ejection fraction. So that stroke volume is how much blood the left ventricle puts out. Cardiac output is stroke volume times heart rate. So we have a decreased stroke volume, you're going to have a decreased cardiac output. Diastolic dysfunction. So diastolic is when the heart is resting and filling. So this is a filling dysfunction. You have stiffening of the ventricles. You have compromised diastolic or filling ability. Again, filling dysfunction. You will still have a decreased stroke volume and cardiac output because the heart is not able to fill, but the ejection fraction is unaltered because it is still emptying, it's just not filling. So big differences between systolic and diastolic. You have emptying dysfunction versus filling dysfunction, dilated ventricles versus stiffening of the ventricles, and then you have decreased stroke volume and cardiac output and ejection fraction versus decreased stroke volume and cardiac output, but regular or unaltered ejection fraction. Breaking it down into left and right heart failure, it'll be on 2 slides. So left heart failure is the most common type of heart failure. The left ventricle has decreased output, making the body have decreased blood flow. Since the right ventricle is still functioning, the lungs get increased blood flow. This leads to pulmonary edema with symptoms such as wheezy breathing, sounds, shortness of breath, and fatigue. Right heart failure is the opposite, so the right ventricle has decreased output leading to decreased blood flow to the lungs, but the left ventricle has normal function leading to increased blood flow to the body, and this leads to peripheral edema. Now comparing right heart failure to left heart failure. Right heart failure does have this dependent edema or pitting edema. It will be bilateral, and you want to be sure to document the amount of pitting as well as the area of edema. But left heart failure will have that pulmonary edema, so within the lungs. Right heart failure will have all these amegaly, so basically enlarged liver, a large spleen, jaundice. They will have some swelling ascites and ascaria. So ascites is buildup of fluid in the abdomen, and ascaria is just generalized swelling. They'll have fatigue, murmurs with the pulmonary or tricuspid insufficiency, and then they'll have a loss of appetite, nausea, bloating, jugular vein distension, and cor pulmonale, or right heart failure due to COPD. Left heart failure is the most common cause for right heart failure. Pulmonary edema will have difficulty breathing, increased respiratory rate, pallor, or cyanosis. And the rest of these left heart failure symptoms is all related to difficulty breathing. So progressive dyspnea, orthopnea, paroxysmal nocturnal dyspnea. Those words are all fun to say, but just a lot of breathing difficulties related to that pulmonary edema, related to that overload of fluid within their lungs. They will also have fatigue and weakness. They might have mitral or tricuspid regurgitation, pulmonary rales and crackles, so that's also related to fluid in their lungs, and they might also present with an S3 heart gallop. So with this picture, I tried to place all the right side dysfunctions on the right and the left heart failure stuff on the left of the patient's body. And I didn't point out everything, but if you can kind of remember these few things, you will likely get the right answer when it comes down to right versus left heart failure. So right heart failure, that jugular vein distension, enlarged liver and spleen, loss of appetite, peripheral edema. And remember, it is most often caused by left heart failure. And then with the left heart failure, it's going to have a lot of lung dysfunction, so pulmonary edema, rales and crackles, dyspnea, shortness of breath, possibly valve regurgitation, and S3 gallop. So when it comes down to medical diagnosis for heart failure, what are we going to be looking at? So you can look at imaging, an enlarged heart and flattened diaphragm, opacities in the lung fields, or a blunted claustrophrenic angle. For labs, they're going to look at BNP, which is B-type natriuretic peptide. Normal levels are less than 100, but the labs would be over 500. That indicates heart failure. And then they will also get an echo to establish the ejection fraction. So normal ejection fraction is 55 to 70%. Dysfunction is 30 to 40%, and then failure is 30 to 35%. So the classification of heart failure, there's 4 classes, and class 1 is the best class, class 4 is the worst class. So class 1, no symptoms or no limitations with ordinary physical activity. Symptoms include like dyspnea, fatigue, palpitations, so just know that moving forward. Class 2, there's symptoms with ordinary activities. So ordinary activities is about 4.5 METs, which are things such as light swimming, light golf, shooting basketballs, fast dancing, and walking about 4 miles per hour. So just those ordinary activities. Class 3, symptoms with less than ordinary activities. So that is 3.0 METs. 3 METs are things like bathing, cooking, washing the car, sweeping, light gardening, or walking at 3 miles per hour. And then class 4, you have symptoms at rest. So this is when it's gotten really bad. You're always having fatigue, dyspnea, and palpitations. Next, medical management. Medication-wise, they could be on anticoagulants or antihypertensives, such as ACE inhibitors, ARBs, and beta blockers. Digitalis, which is to increase the strength of contraction. Diuretics, these help decrease the workload because it helps get fluid off. The antihypertensive kind of decreases the workload by vasodilating and bringing down the heart rate and blood pressure, but the diuretics is decreasing workload by getting the fluid off. Procedures, so you would have a procedure if it would fix the underlying cause of the heart failure. So procedures like a CABG, coronary artery bypass graft, a heart valve repair, a pacemaker or defibrillator, or an LVAD. And then patient education, we're going to provide patient education on lifestyle changes such as smoking cessation, restricting sodium intake, maintaining a healthy weight, limiting alcohol and fluids, stress reduction, and moderate exercise. So what is the criteria to initiate exercise? We want to make sure that the heart has been compensated. The resting heart rate is less than 120 beats per minute. Conversational with respiratory rate of less than 30 breaths per minute. Central venous pressure less than 10 milligrams of mercury. Crackles in less than half of the lungs, and cardiac index greater than 2 liters per minute. What is the criteria to modify or terminate exercise? So when their respiratory rate has gone over 40 breaths per minute, when they have marked dyspnea or fatigue, development of the S3 heart sound, pallor, diaphoresis or confusion, increase in pulmonary crackles, decrease in heart rate or blood pressure of 10 beats per minute or milligrams of mercury. And when you have a decrease in heart rate or blood pressure, that means your heart is not able to keep up with the exercise, and that is when you need to terminate the exercise. And if your central venous pressure increases by 10 millimeters of mercury. So if you kind of keep an idea of what that criteria to initiate exercise is, basically you just scale it up, and that's when you need to modify or terminate exercise. So you can start when their breaths per minute is less than 30, but if it gets over 40, you need to modify or terminate. And then you can have some crackles in the lungs, but when you have an increase in crackles, you want to modify or terminate exercise, and then keeping a check on their heart rate and blood pressure. So what does exercise look like? So you will do aerobic training, low and slow, and have some RPE monitoring. So RPE monitoring is to measure the intensity of exercise, because if they're on beta blockers, we are not going to be able to monitor their heart rate to assess exercise intensity. And then strength training, we are going to do it based off their classification of heart failure. So if they're in a class 1, we might do 50 to 60% of their 1 rep max, 2 to 3 sets of 6 to 15 reps, 2 to 3 times a week. Class 2 to 3, we're going to work at a little bit lower load, so 40 to 50%, 1 to 2 sets of 4 to 10 reps, and only once or twice a week. What is the RPE scale? So the RPE scale goes from 6 to 20, but the modified RPE is 0 to 10, so kind of whatever you want to educate your patient on, but really explain to them that 6 or 0 is at rest, 20 or 10 is at that max exertion. And we don't necessarily want them to be there, but we want them to understand that's what the limit is. And you can also describe it, like, do you feel like you're working very, very hard? Do you feel like you're working fairly light, somewhat hard? And sometimes that still doesn't quite make sense, but we are going to prescribe an RPE based on our estimated percent max heart rate. So again, we can't look at their max heart rate, but we might look at like, hey, we want them to be working at 60 to 70% intensity. So that means I want them to work at a 10 to 12 RPE. So describing what RPE is to them at the beginning of exercise, and kind of always checking in with them so you know where they're at to assess if you need to take a rest break or continue working. Okay, time for questions. So we are going to do a scenario-based question today. I'll read out the information, but this information will be on the practice question, on the actual practice question slide. So setting: outpatient, sex female, age 72, presenting problem / current condition, 3-day hospitalization due to heart failure management, reports fatigue and difficulty breathing with light housework activity, their medical history, hypertension and heart failure, other information, 1-story home with husband, walks with a walker, physical therapy examination, tug, 15 seconds, 2-minute walk test, 100 meters, 4 out of 5 gross lower extremity strength, pitting edema 2+ in bilateral lower extremities, and crackles. Vital signs and before activity. So blood pressure is 146/84, heart rate 82, respiration rate 20. After the 2-minute walk test, their blood pressure is 152/84, heart rate 86, and respiration rate 35. So practice question number 1, the change in heart rate from before to after the 2-minute walk test is most likely due to which of the following medications? A, Lasix, B, heparin, C, metoprolol, D, Lipitor. I'll give you a moment to answer. Please pause if you're not ready to review. The change in heart rate from before activity to after the 2-minute walk test is most likely due to which of the following medications? So she went from an 82 to an 86. Is that what you would expect from exercise after walking for 2 minutes? Maybe if you're not working that hard, but you can tell from her respiration rate, she goes from a 20 to a 35. So I believe she's working relatively hard or has some, increased activity, and in the information that she is reporting difficulty breathing with light housework activity. So walking for 2 minutes will probably get her working out pretty well. I'm thinking that she might be on a beta blocker, because we know that a beta blocker limits heart rate, but our answer choices are not drug categories, they're specific drugs. So now we have to kind of recall What are these drugs and what are they doing? So a Lasix is a diuretic, which they could be on because people with heart failure are prescribed diuretics, but typically that does not affect heart rate. Heparin is an anticoagulant, which they could be on when in heart failure, but that doesn't typically affect heart rate. Metoprolol is a beta blocker. So metoprolol is probably the answer. Let's look at D. So D, Lipitor, is a statin for high cholesterol, and our patient does not have high cholesterol. They also that is not indicated for a patient with heart failure. So D does not sound right. So C, metoprolol is the best answer. It is a beta blocker, and it will limit the heart rate during exercise. You should use the RPE during exercise to measure intensity of the workouts. Practice question number 2, which of the following is the recommended protocol for strength training for the patient? A, 40 to 50% 1 rep max for 1 to 2 sets of 4 to 10 reps. B, 40 to 50% 1 rep max for 2 to 3 sets of 6 to 15 reps. C, 50 to 60 1 rep max for 2 to 3 sets of 6 to 15 reps. D, 50 to 60 1 rep max for 1 to 2 sets of 4 to 10 reps. I'll give you a moment to answer. Please pause if you're not ready to review. You know the patient has heart failure. It says that in the reason why they were hospitalized, they had heart failure management. And strength training protocol is dependent on the class of heart failure. So what class of heart failure do you think this patient is in? So class 1 is no limitations with ordinary physical activity. Class 2 is symptoms with ordinary activities. Class 3 is symptoms with less than ordinary activities, and Class 4 is symptoms at rest. So this patient reports fatigue and difficulty breathing with light housework activity. So light housework activity is 3.0 METs. So that would be Class 3, symptoms with less than ordinary activities. So based on knowing the patient is in Class 3 heart failure, the strength training protocol is A, 40 to 50% 1 rep max for 1 to 2 sets of 4 to 10 reps. C would be the best answer for Class 1 heart failure, and Class 2 and Class 3 are in the same group. So A could be the correct answer for either Class 2 or Class 3. B and D are made up answers kind of in between or a mix of the two different training protocols. So A, 40 to 50% 1 rep max for 1 to 2 sets of 4 to 10 reps. Okay, last question. Which of the following is recommended for patient education for this patient? A, restrict sugary foods. B, restrict salty foods. C, drink plenty of fluids. D, weigh once a month. I'll give you a moment to answer. If you're not ready to review, please pause. This question, patient education for patient with heart failure. So restrict sugary foods. I feel like, yes, that should be recommended for everyone, but maybe not the best answer for this patient. Restrict salty foods. Well, that could be right because we want to restrict salty foods because the more salt you eat, the more water you retain. And with heart failure, you have to be more careful with that excessive fluid. But let's look at the other answers. C, drink plenty of fluids. You do want to make sure you're hydrated. You want to monitor or limit the amount of fluids that you're intaking. D, weigh once a month. So you're actually going to monitor your weight gain every day and call your doctor if you gain 2 pounds a day or 5 pounds in a week. because that could indicate that the heart has uncompensated and that you have too much peripheral edema or fluid in your body. B is the best answer, restricting salty foods because of its relation to water and how that will cause your body to retain more water. Thanks so much for watching. Don't forget to like this video, subscribe to our channel, and turn on notifications. See you next time on your journey to 600.